Good morning, and I'm very happy and excited to welcome you all to this fifth event of the MSF Pediatric Days. This year, we have had more than 1,350 delegates register for this conference, and that is fantastic. We're joined on this platform by people from all over the world, as you can see on the platform's networking lounge. I am Myrto Schäfer, and I'm joining from Greece. I will be the moderator for today's event. Before we start, I want to take a moment to thank MSF Sweden and MSF OCPA, who are the sponsors for this event, and without whose support it would have been impossible to hold this and all previous and hopefully future pediatric days. Thanks so much. Now a few words to the title of the day, Together for Better Care. While the session after the break on zero separation will be exclusively on the mother-baby pair and family-friended care, the rest, and particularly the first part of all the morning, will also take into consideration the larger picture. It will try to showcase how multifaceted the approach to infant care needs to be. Good care can only be achieved if we take into consideration the context, build responses that are contemporary and comprehensive, responding holistically to the children's needs. It is about looking at health delivery systems and how to work collaboratively within the system and with the stakeholders around us. What equipment is needed and how we can best be trained and how we can provide the best possible training. What are the resources needed? And how can we extend care beyond the walls of a physical health structure and provide a quality continuum of care? Best results can only be achieved if we integrate context-adapted psychosocial and mental health care with physical care and interventions. We need to start with the right mindset, use expertise, experience, and knowledge around us, and implement programs within and together with the communities we work for and in, and then monitor and follow those up with evaluations to feed back into further improvement of our care. And we must advocate for those who do not have a voice and share our successes and lessons learned. So today we will hear about experiences on how to better implement care together. We will hopefully have the opportunity to exchange on our own experiences and walk away inspired and with new ideas on how to translate some of what we have heard today into action. A few words on housekeeping. I hope you all had the time to familiarize yourself with the virtual platform and had a chance to watch the introduction video. If not, you will find it at the help desk on the homepage. Apart from listening to the presentation from the auditorium today, where you will be spending most of your day, you can use the other interactive functions and visit the virtual rooms during the breaks, go to the booths, meet other delegates, look at posters in the poster hall, and use the resource library. You can post a picture at the photo gallery, particularly if you're watching as a group, and you can post on the chat and say who you are and where you're joining from. Most of the functions will be available for a couple of weeks after the conference, so you can use your time today to follow the live event. If you have joined the meeting with a bigger group, please register individually. That way we can later see how many people participated and from where. And you will be also able to use all the other interactive features like questions and answers, conversations over coffee, etc. At the end of the day today and at the end of the third day, there are workshops. Those of you who have registered, please make sure that you check your email so you know how to join and to your respective workshop. So without further ado, I want to introduce our first speaker of the day for the opening address, Maria Guevara. Maria is a pulmonary and emergency physician and holds a master's in global health policy from the London School of Hygiene and Tropical Medicine. She started her humanitarian work almost 20 years ago in 2004 in Liberia with MSF. Maria has held a long list of different senior positions in MSF and with WHO. Previous to her current position as MSF's International Medical Secretary, she was senior advisor on global health and senior coordinator for attacks on healthcare. Maria, welcome and thank you. The floor is yours.
Thank you, Myrto, for the introduction and the warm welcome. Greetings from Geneva. In return, I also welcome you all online, wherever you may be connecting to this 5th edition, second virtual edition of MSF Pediatric Days. It's quite amazing that this conference or event, which started out, which started out back in 2014 as the seed of an idea in returning MSF field staff. So they were driven by an instinct and the wish to provide more than just resources, but true support in improving the quality of pediatric medical care in MSF missions. This seed became a reality as the first ever MSF Pediatric Days in Stockholm on September 2016. It was attended then in person by 180 participants. And while live streaming had always been part of this setup, it was not until last year when it became fully virtual, so reaching so many more people, sharing the wealth, so to speak, with more than 1,000 participants all calling in online. And today, that's the same case, and saving carbon at the same time. Bravo for this. To me, this seemingly simple act of connecting virtually, and not to underestimate the incredible planning and organization that goes on to make this happen, are important steps to the what and how we need to be considering as new ways of working. As we look into the future, learn from COVID, and push ahead in a globally warming world. And this simple act also provides an important opportunity to bring visibility to share experiences on, and to learn from each other about the critical action of medical care in humanitarian settings, specifically pediatric care, through the MSF lens of the past, at the present, and into the future. So let's start in the past. Who are we? Where have we come from? And why are we here? In December 1971, MSF was born in the wake of the Biafra Secession War in southern Nigeria, where the Biafran people were decimated by famine, with children dying in numbers from hunger. The instinct and wish to do something were already there. In a group of young doctors who decided to go and help victims of wars and major disasters and bear witness to the horrors these victims were going through. For them, it was a simple act of going where the patients and the needs were, to quote Bernard Kouchner. It's simple, really. Go where the patients are. Seems obvious, but at the time it was revolutionary. We wanted to ensure sufficient knowledge of this new type of medicine. And with that, MSF became the first international humanitarian organization that specialized professionally in medicine. In December 2021, MSF turned 50. 50 years of providing humanitarian medicine in the most challenging, hard to reach, and conflict-ridden settings, driven by medical ethics and humanitarian principles. In between these milestone dates was that of 1999, the year MSF was awarded the Nobel Peace Prize, which provided the funds for the creation of the Access Campaign for Essential Medicines to address the political, economic, and legal barriers to patients' access to life-saving treatments. Driven by the growing experience and frustrations of feeling powerless in the field due to the lack of quality care in essential medicines, coupled with rising drug resistance to treat infectious diseases as malaria, TB, meningitis, sleeping sickness, other NTDs. This represents the clear action of pushing for equitable access to quality care and waking the world up to the inequity that exists. Again, the instinct and the wish to do more and better were there. Now, coming to the present, where are we today? In numbers, in 2021, MSF reported running 893 projects globally, 55% of which were in unstable or conflict settings, with a workforce of nearly 50,000 staff, which began at 300 in its early days. MSF field teams provided 12.6 million outpatient consultations with 1 million inpatient care, 2.7 million malaria treatments, 1.6 million measles vaccination, 82,000 treatment for severely malnourished children, over 300,000 assisted births, including cesarean sections. That's just to name a few. In quality, this is a bit harder to show, but work is definitely ongoing to ensure a quality improvement process is in place, enforcing a culture shift to a shared approach to quality care. What we do see, however, if we are to link it to the main objectives of this pediatric gaze, are one, an important and constant growth these last few years in inpatient pediatric and neonatal care. In this last year, pediatric hospitalization represented 42% of global volume, with neonatal hospitalization making up 5% of that 42%. This highlights the increasing capacity in this field, especially in conflict areas, probably much thanks to all these kinds of exchanges that is happening in this event. A shift also in HIV care to the more neglected regions and populations, meaning an increased focus on pediatrics and adolescents. A push for a more multidisciplinary approach to break the silo between provision of care for the mother and that of the child. And those progress includes collaborative work between the different working groups as the lab, the TB group, the HIV group, with the pediatrics, as well as the maternal health group, on a number of areas from chronic care guidelines to developing shared priorities and clarification of diagnostic algorithms. There's been a growing focus on more community-based, or rather community-led approaches, as with operationalizing the integrated community case management approach. There's been an expansion of malnutrition treatment to include more and more the care for moderate acute malnutrition along with the SAM cases. And there's been more active work on medical advocacy as with not neglected tropical diseases, whether from snake bites to Noma, the latter of which you will have the honor to listen to Mulikat, Noma survivor, to give her testimony in day 3. All these improvements are and will prove ever more critical as we look to the challenges ahead, which brings us into the future and what lies ahead for us. Sadly, it means more challenges, more emerging threats. And COVID was and is, as it continues to trot around the globe again and again, our dress rehearsal to what lies ahead, showing us our inseparability and our collective unpreparedness, and continues to remind us of a new frontier of fragility and vulnerability. That also means the crisis of tomorrow, not only where we go in a spirit of solidarity to save lives in traditional, quote, humanitarian hotspots, but it will also be in the developed world, the so-called North. But while COVID wreaked havoc in all corners of the world, it remains very clear the impact of COVID has been disproportionately and inequitably borne by certain populations and countries as we face the ethical dilemmas of field reality, not being able to provide the novel vaccines the rich had access to. What can we take home as lessons to ensure more equitable access to quality treatment and preventive care for the next pandemic? As it is almost a given that COVID is not a one-shot. With biodiversity loss, climate change, and land degradation going unabated, it will just be the first of many. Let us hope it is not, but there is no doubt that climate change exists, and tomorrow you will be hearing from Dr. Bhutta on this. But as an intro, according to the 6th assessment report of the Intergovernmental Panel on Climate Change, the verdict is grim. It means the planet is no doubt heating at a rate never seen before, and it is our fault. Yes, us humans. And there is little hope remaining of avoiding a worst case scenario. The effects of climate change will be overwhelmingly negative, with the most vulnerable being the most impacted. And those vulnerable groups include indigenous populations, local communities, the elderly, women, and of course, the children. Highlighting clearly the climate crisis is a humanitarian crisis. The report also unequivocally links climate change to negative health impacts, from extreme heat causing increased disease and death and more frequent and more severe extreme weather events, to increasing incidence of foodborne, waterborne, and vector-borne diseases, definitely more malnutrition due to rising food insecurity, emergence of new infectious diseases, especially of animal origin as with COVID, or even a rise in chronic diseases, on how climate change and environment degradation contributes to violent conflict and population displacement. And then for the first time, mentioning how mental health is negatively impacted by climate change. Again, the climate crisis is also a health crisis. Having just come back from COP27, where the discussions on loss and damage has finally come officially to the table after 28 years of meeting, there were some wins and some losses. To just quickly explain, the UN climate negotiations approach on loss and damage is in 3 distinct ways. 1, averting loss and damage, meaning reducing greenhouse gas emissions, minimizing loss and damage, as with assisting people and communities to adapt and prepare to the extent possible. And 3, addressing the loss and damage by dealing with and recovering from the consequences of the climate impacts, which is happening today in our fields. While there continues to be a battle on truly committing to facing down on all fossil fuel use, an agreement was reached to create a loss and damage fund. And for the first time, health issues made its way into the official document with a reference to the right to a clean, healthy, and sustainable environment. But the more poignant and tangible outcomes of the COP are actually the people and the advocates present fighting for social and climate justice. Hearing Rosamond Adu-Kisi Deborah, ambassador for the Brief Life and mother to Ella, her 9-year-old daughter who died from repeated asthmatic attacks, and whose death certificate officially states that air pollution contributed to her death, the first ever reference, tirelessly pushed for the right policies to be in place and succeeded to have Ella's law bill passed that establishes the right to clean air in the UK. For Dr. Arvind Kumar, leading cardiothoracic surgeon in India, and of Doctors for Clean Air, passionately pleading for climate action, as it shows us pictures of the black lungs of a newborn baby he had to carry out surgery on. At MSF, we are working to understand what climate change and environmental degradation means for us, and how we need to address the impact on the populations we serve. For some, we use the framing the planetary health approach, viewing health within an ecosystem where human health is interdependent and inseparable to that of Earth health. We are also framing our actions through the 3 pillars of operational adaptation, along with operational research and anticipatory action, as with the Malaria Anticipation Project, a footprint mitigation as through establishing carbon roadmaps, and advocacy as in building knowledge and adding voice to climate witnessing. But we are only one cog in the wheel of humanity, doing medical humanitarian work and addressing the ever-increasing, compounding, complex, and cascading emergencies that are already in the present, and that will only get worse in the future before our whole village, whole of society working together in solidarity. All this is simply to say the richness and the value of exchange held in an event such as this cannot be overstated. The collaborative efforts of learning from and between every experience of each contributor on best practices, the links and connections made are born from the instinct and the wish to do more and better. This is precisely where we can take the next steps together in ensuring that the future of pediatric care and humanitarian medicine at large means simply good, quality, equitable, and sustainable medical care. Thank you for your instincts and the wish to be here today. Wishing you all a great and productive conference. Thank you.
Thank you, Maria.